Hello students, I am Dr. Janani, Assistant Professor from the Department of Prosthodontics, Vinayaga Mission Sankaracharya Dental College. And today our topic is Special Impression Procedures for Tooth Tissue Supported Removable Partial Dentures. See, the occlusal forces are applied to a tooth supported removable partial denture directed through rests and transmitted to the abutments. So, the edentulous ridges do not contribute to the support of the partial denture because the teeth will absorb these forces and the forces can be transmitted to the tissues of the residual ridge. Since the denture base does not contribute to the support of the partial denture and the underlying mucosa and bone are not subjected to functional forces, a tooth supported removable partial denture can be constructed on a master cast made from a single impression that records the teeth and soft tissues in their anatomic form. So, what they are trying to tell is you are going to take a tooth supported removable partial denture impression. For that, you need only a single impression and a master cast made from a single impression. So, when the occlusal forces are applied to a tooth tissue supported removable partial denture, these forces must be equally distributed between the abutment teeth and the tissues of the ridge. A dual impression technique is used in which a corrected cast is generated. The impression of the teeth is made with a material that captures the teeth in their anatomic position. So, we make an impression in which the teeth is captured in the anatomic position, whereas in contrast, the impression of the residual ridge must record the soft tissues in their functional form. In this diagram, you can see that the forces applied to a tooth tissue supported removable partial denture should be equally distributed to the abutments and the tissues of the ridge. The impression of the residual ridge must record and relate the tissues under uniform loading, and it should distribute the load over as large an area as possible, and it should accurately delineate the peripheral extent of the denture base. So, you can see that the forces on a tooth supported removable partial denture, it is transmitted through the rests. Through these rests, it is transmitted to the abutments. Now, we will see what are the factors influencing the support of the distal extension base. So, the first factor is the quality of the soft tissue covering the edentulous ridge. The soft tissues covering the bony residual ridges are compressible to varying degrees. So, if the soft tissues are thick and displaceable, you get only less support for a denture base, whereas a firm, tightly attached mucosa displaying a moderate thickness will offer the greatest support. And for example, if redundant tissues have accumulated, say in the maxillary tuberosities, you have to surgically remove it. And the removal of the redundant tissue not only minimizes the vertical displacement of a denture base, but also it improves the resistance to lateral displacement. The next factor is the type of bone in the denture bearing area. See, we all know we have two types of bone, which is cortical and cancellous bone. Cancellous bone, as compared with the cortical bone, is less able to resist vertical forces because its irregular surface acts as an irritant to the overlying soft tissue if vertical stress occurs. So, what happens as the result of irritation? The irritation is going to cause chronic inflammation, which may lead to oral discomfort and in turn accelerated ridge resorption. Therefore, the areas of cancellous bone should not be considered as primary stress bearing areas. Instead, the practitioner should direct the forces to dense cortical regions such as the buccal shelf. So, in this diagram, you can see these are the cancellous bone, which is going to cause irritation to the underlying mucosa. Next factor is the design of the prosthesis. We should have a knowledge of the basic mechanical principles that guides the management of functional forces in partially edentulous arches. Rotational forces passing through the most posterior clasp assemblies can be controlled using appropriate components. So, what is the most efficient method of controlling the rotational movement? It is going to be the placement of indirect retainers anterior to the fulcrum line. You know that the fulcrum line connects the most posterior abutment teeth and the indirect retainer should be placed anterior to it. So, can you see the indirect retainer it helps control the rotation of the prosthesis, and it limits the movement of a distal extension base. The next factor is the amount of tissue coverage of denture base. To counteract the tissue work component of a rotational force, such each distal extension base must cover a relatively large surface area. The broader the coverage of the edentulous ridge, the greater is the distribution of the load, and all available space must be used without encroaching on the movable tissues. What happens if you give overextension? Overextension of the denture base may cause irritation and ulceration of the soft tissues, as well as lifting or dislodging forces on the prosthesis. This may result in torquing of the clasped abutments and orthodontic movement of the teeth anterior to the fulcrum line. So here we can see that the overextension of the denture base will cause rotational forces, which will result in orthodontic movement of the teeth anterior to it. The next factor is the anatomy of the denture bearing area. Occlusal forces must be directed to the portions of the ridge which are most capable of withstanding the forces. So if you should know which areas are capable of withstanding forces, you should understand the anatomic and structural characteristics of maxillary and mandibular arches. So now first we will see about the maxillary edentulous ridge. So which do you think is the primary stress bearing area in the maxillary arch? It is going to be the crest of the ridge, and few structures other than the crest of the ridge are capable of serving as the primary stress bearing areas. The buccal slope of the maxillary ridge is normally covered by a layer of cortical bone, so it can withstand a significant amount of stress. Unfortunately, the buccal slope of the maxillary arch, it is not oriented to the perpendicular to the vertical forces occurring against it, so it offers little resistance to them. So you have to understand that though it is made up of cortical bone, the orientation is not perpendicular to the forces, whereas the buccal slope can resist the lateral forces. Some resistance to vertical displacement can be derived from the horizontal portion of the hard palate, and again unfortunately the tissues of the hard palate are relatively thin and incompressible. Therefore, tissues of the hard palate are susceptible to irritation and ulceration. So based upon the foregoing considerations, the majority of denture based support of a maxillary distal extension partial denture must come from the crest of the ridge. The mucosa covering the crest is usually firm and it is capable of resisting the occlusal forces. In case the crestal mucosa is not firm and dense, it should be surgically corrected to provide an appropriate foundation for the prosthesis. Next, we will talk about the mandibular edentulous ridge. Here, the crest of the mandibular ridge cannot be used as the primary stress bearing area. What is the reason? As you all know, it is composed of cancellous bone and it is covered by soft tissues that are more susceptible to injury than those in the maxillary arch. Fortunately, the dense cortical bone of the buccal shelf area makes an excellent stress bearing site. So you have to understand that in the mandibular, the primary stress bearing area will be the buccal shelf. The soft tissues covering the cortical bone in this region are usually firm and dense, and the anatomy of the buccal shelf area is nearly perpendicular to the forces of occlusion. Therefore, this region will tolerate the accompanying stresses. And what about the horizontal forces? That is being tolerated by the buccal and lingual slopes of the residual ridge. So as you can see, the horizontal portion of the hard palate and the slopes of the residual ridge are considered as the primary stress bearing areas for the maxilla, whereas only the buccal shelf is considered the primary stress bearing area for the mandible. What about the fit of the denture base? Each denture base must be made to fit the areas that can be served as the primary stress bearing areas. Indications. So when will you use a dual impression technique? See, dual means you are taking the impression in two stages. So how will you find out? You have a test. You add acrylic resin bases to the framework, and then the framework is placed in the mouth. Then you apply finger pressure to the base. If the base can be depressed enough that the indirect retainers or lingual plating lifts away from the teeth, that means a dual impression technique should be used. But if there is no discernible movement, consideration should be given to a single impression technique. It should be noted that dispensing with the dual impression procedure eliminates the opportunity of establishing precise and functionally formed denture borders. Now we will move on to the impression techniques. There are two categories of dual impression techniques. They are defined as physiologic impression techniques and selected pressure techniques. So what is it? Physiologic impression and selected pressure. So as the name suggests, the physiologic impression technique will record the rich portion of the cast in the functional form. See, in the cast you have a rich portion and the tooth portion. So the rich portion is captured in the functional form by placing an occlusal load on the impression tray during the impression procedure. And there are three physiologic impression procedures, which is McLean-Hindel's method, the functional reline method, and the fluid wax method, which we will see one by one. Selected pressure techniques, as the name suggests, it is intended to equalize the support between the abutments and soft tissues and to direct forces to the portions of the ridge that are most capable of withstanding such forces. So how will you accomplish this? This is accomplished by relieving the tray in some areas while allowing the impression tray to contact the ridge in other areas. In areas where relief is provided, they are minimally displaced during the impression procedures, and where you do not provide relief, there is going to be a greater soft tissue displacement. In both the fluid wax technique and the selected pressure technique, an impression of the edentulous ridge is made using an impression tray which is attached to the framework. Framework means you should understand it is going to be a cast partial framework, and the master cast is altered to accommodate the secondary impression and a corrected cast is generated. See, these terminologies you have to understand. First you have a master cast, and that master cast is altered so that you can get a corrected cast. So this technique is referred to as a corrected cast or altered cast procedure. So what is McLean's physiologic impression? So the need for physiologic impression was first proposed by McLean and others because they realized the need for recording the tissues of the residual ridge in functional form. See, the residual ridge should always be captured in a functional form, whereas teeth should be captured in the anatomic form. That is why it is called dual impression technique. One is the functional form and the other is the anatomic form. To accomplish their objectives, they constructed a custom tray, that means a special tray on a diagnostic cast. So here can you see the special tray is fabricated over the diagnostic cast. A functional impression is made using this tray with a suitable impression material. So first an impression is made with the special tray over the ridge. Next, a hydrocolloid over impression. Hydrocolloid means alginate. Over impression means pickup impression. So we make a pickup impression with alginate was then made while maintaining the functional impression in the intended position. The greatest weakness of this technique was that practitioners could not produce the same functional displacement generated by occlusal forces. So as I told you, you have two impressions. One is the functional impression which is made using a special tray. The other is the hydrocolloid, that is the alginate impression, which is going to be the over impression or the pickup impression. So in response to this shortcoming, Hindels and others developed a modified impression trays for the second impression procedures, and these trays had large holes in the posterior segments. So with the help of the holes, what happens, the operator can actually apply finger pressure, and the finished impression was a reproduction of the anatomic surface of the ridge and the surfaces of the teeth. See, these two were related to each other, however, as if masticating forces were taking place on the denture base. So as I told you, the modification that Hindel gave is two large holes on the impression tray so that finger pressure can be applied. Disadvantages of these techniques are closely related to the direct retention. If the action of the retentive clasps is sufficient to maintain a denture base in its intended position, the tissues of the ridge will be in the functional form. This may result in compromised blood flow with adverse soft tissue reaction and resorption of the underlying bone. If the action of the retentive clasp is not sufficient to maintain the functional relationship of the denture base to the soft tissues, the denture base will be occlusally positioned when the soft tissues are at rest. This results in premature contact of the artificial teeth, which may be objectionable to many patients. So far we have completed about the McLean's and Hindel's physiologic impression method. So the next technique we are going to see is the functional reline method. See, you have to closely watch the terminologies. What do you understand by functional reline, or what do you understand by relining? Relining means you are adding something to the existing denture base. So most methods of obtaining a physiologic impression for support of a distal extension denture base require accomplishment of the impression procedure before completing the prosthesis. It is possible, however, to obtain equally effective results even after the partial denture has been completed. The technique has been referred to as the functional reline method, and it consists of adding a new surface. Where are we adding the new surface? To the interglio surface of the denture base. The procedure may be accomplished before the insertion of the partial denture, or it may be done at a later date if the denture base no longer fits the ridge adequately. Although the functional reline method has many advantages, it also presents many difficulties. What are the difficulties? Failure to maintain the correct relationship between the framework and the abutment teeth during the impression procedure, and failure to achieve accurate occlusal contact following the reline procedure. So the partial denture is constructed on a cast which is made from a single impression. See, note this carefully. So you are generating a partial denture, and that is made from a single impression using alginate. So if you make a single impression, it is called an anatomic impression, and no attempt is made to alter it or produce a functional impression of the edentulous ridge. To allow room for the impression material between the denture base and the ridge, space must be provided. How will you give space? The accurate method of ensuring uniform space is to adapt a soft metal spacer over the ridge on the cast before processing the denture base. Can you see? This is the metal spacer that is applied to the ridge before processing the denture base. Now, the portion of the technique that will introduce the greatest hazard is the reline impression procedure. What will happen? During the relining, the patient must keep the mouth partially open throughout the procedure. So what material do you use? You use a low fusing modeling plastic that is applied to the interglio surface of the denture base, tempered in a water bath, and then it is seated in the patient's mouth. So basically this is a bottom molding procedure. You can see that the impression is added for relining and it is molded. You get an accurate molding of the denture base. So now since you have made the impression, now we are going to make another impression, which is the secondary impression. We have done the bottom molding, we are going to use a secondary impression. To provide space for the impression material, 1 mm of modeling plastic is removed from the interglio surface. Then an impression is made with zinc oxide eugenol or a light bodied polysulfide rubber base. This will be the secondary impression. In the functional reline procedure, as in all reline procedures, occlusal discrepancy, see, in any reline procedure you will have occlusal discrepancies, and this must be corrected after the new denture base has been processed. Since the open mouth impression technique must be used, it is impossible to maintain the previously established occlusal contacts. If errors in occlusion are slight, the correction may be accomplished in the mouth. However, in a majority of cases, you have to remount it in the articulator to do the occlusal corrections. So, next we will see about the corrected cast procedure. The first step is adding an impression tray. You are going to prepare a corrected cast impression appointment. You require the addition of 1 or more impression trays. So, to which you will add the impression tray? Over the framework. What material you are going to use for the impression tray? You are going to use a chemically activated or light activated resin. So, before adding the impression tray material, you can see that the master cast has to be carefully examined for the undercuts, because undercuts that would be interfere with the removal of the tray are blocked out using base plate wax. An appropriate separating medium is then placed on the corresponding area of the cast and the framework is completely seated. You can see that a separating medium is applied, and this is what I told you, it is the cast partial denture framework which is accurately seated on the cast. A chemically activated or light activated resin is adapted to the struts of the minor connector. See, I showed you a cast framework. Now you can see that we are adding a denture base to the framework. This is how you add an impression tray to the framework. And you can see the borders are trimmed with a laboratory knife. Following polymerization, the denture base is trimmed and smoothened using laboratory burrs and arbor bands. Correcting the peripheral extension. See, it is a simple procedure. You must have been doing border molding in your clinics. So what is the first step? You put the special tray in the mouth and check for extensions. It is the same thing. The buccal extension of the tray is observed as the cheek is moved downward, upward and outward. As this movement is taking place, the edge of the tray should be 2 to 3 mm from the depth of the buccal vestibule. In simple words, it should be 2 to 3 mm short of the sulcus. And posteriorly, the mandibular tray should reach 2/3 the height of the retromolar pad. And you have to observe this directly. And the distolingual length of the tray is assessed by directing the patient to place the tip of the tongue against the upper lip, and the operator's fingers should rest slightly on the tray during this process. So you can see, you can feel if the tray is going to lift even slightly during this movement, the distolingual length should be shortened. The remainder of the lingual flange is evaluated by having the patient place the tip of the tongue into each cheek. This is for the right and left lateral movements. This movement need not be forceful, but only enough to distend the cheek slightly. The operator's fingers are used to detect the movement of the tray. Lifting of the mandibular left tray is usually produced when the tongue is placed in the right cheek. What happens when the tongue goes and touches the right cheek? The left tray will lift, while the lifting of the mandibular right tray is produced during a leftward movement of the tongue. The practitioner should assess these movements and make appropriate adjustments to the lingual flanges. So once your tray extensions are correct, moderate manipulation of the border tissues, including thrusting the tongue forward into both the cheeks, should not produce any movement of the tray. That means the patient is going to do any tongue movements, there should not be any movement of the tray. An overextended tray will cause a constant force to be placed on the abutment teeth as the border tissues attempt to unseat the denture. So, since we have completed checking the tray extensions, we will move on to the border molding of the impression tray. A mandibular distal extension. So, by this time you should be familiar with what is a distal extension. Distal extension means Kennedy's class 1, which is a bilateral, or Kennedy's class 2, which is a unilateral edentulous area posterior to the remaining natural teeth. So, in 2 steps, that is from the anterior extent of the buccal flange to the most posterior extent of the tray, and on the lingual and distolingual flanges. Border molding for a corrected cast is basically the same as that for a complete denture. The tissue manipulation is also the same that is used in the correcting the peripheral extensions of the tray. Again, you use a green stick compound which is called a low fusing modeling plastic is used for the procedure. See, can you see we have already added the impression tray to the framework and we have checked the extension, and now we have done the border molding on the buccal and lingual sides. Now, how do you relieve the tray and make the impression? When the acrylic resin tray material was adapted to the framework, no relief was provided between the cast and the tray material. This permitted firm attachment of the tray to the lattice work and provided optimum stability during the border molding procedures. At this stage, relief is provided because you need to have a secondary impression. So, the technique for fluid wax functional impression differs from that of the selected pressure impression. Next, we will move on to the next technique, which is the fluid wax functional impression. So far, we have seen the functional reline procedure and the corrected cast technique. This is the fluid wax functional impression. As the name suggests, you will be using a fluid wax to make the impression. So, the fluid wax impression may be used to make a reline impression for an existing partial denture or to correct the edentulous ridge portion of the master cast. The objectives of the technique are to obtain maximum extension of the peripheral borders while not interfering with the function of the movable border tissues. See, to record the stress bearing areas, by this time you should know what are the stress bearing areas that should be recorded in a functional form, and the non pressure bearing areas anatomic form. So, basically we are recording in 2 forms, which is the functional form and anatomic form. The fluid wax impression is made using an open mouth technique so that there is less danger of over displacement of the soft tissues by occlusal or vertical forces. So what is the technique you are going to use? It's an open mouth technique. The term fluid wax is used to denote waxes that are firm at room temperature and have the ability to flow at mouth temperature. So what are the waxes you use? You have Iowa wax that was developed by the University of Iowa, and you have the Correcta wax which was developed by Applegate at the Universities of Michigan and Detroit. The Correcta wax number 4 is slightly more fluid than the Iowa wax. The use of the fluid wax controls critical factors of space and time. Space means it refers to the amount of relief provided between the impression tray and the edentulous ridge. The impression wax flows sluggishly, and a thin layer of wax will flow less readily than a thicker layer. 1 to 2 mm of relief is required between the tray and the tissues of the edentulous ridge. Each time the tray is introduced into the mouth, it must remain in place 5 to 7 minutes. So this time you have to note. So every time you are going to place the fluid wax into the patient's mouth, it must remain in place for 5 to 7 minutes to allow the wax to flow and to prevent the buildup of pressure under the tray with resulting distortion or displacement of the tissue. The clinical technique for the use of fluid wax means you need to have a water bath which is maintained at 51 degrees Celsius to 54 degrees Celsius, into which, so you have a water bath and into which you are placing wax. At this temperature, since it is a water bath, the wax is going to become fluid. Okay, that is why the term you are using is fluid wax. So this fluid wax, you take it and paint it onto the impression tray with a brush. So you can see that there is a water bath and this is the painting of the fluid wax. The peripheral extension of the impression tray is critical. So as we have already seen about the extensions, the borders should be short of all movable tissues, but this space should be more than 2 mm because the fluid wax does not have sufficient strength to support itself beyond that distance. Inaccuracies will develop if the wax is extended beyond the length. Originally, a harder wax, Correcta wax, was used to support the softer wax if extension beyond that length was needed. Okay. Now, this fluid wax is painted onto the surface of the tray to a depth slightly greater than the amount of relief provided. Then you place the tray, you seat it in the mouth. The patient should hold the mouth half open for 5 minutes. So, it is placed in the patient's mouth for 5 minutes and then the tray is removed and the wax is examined for evidence of tissue contact. How will you know whether tissue contact has happened? If there is tissue contact, the wax surface will be glossy, and if there is no contact, it will be dull. For the buccal and disto-buccal extensions in a mandibular impression, the patient must employ a wide open position. You need to record the disto-buccal area, so you are asking the patient to open the mouth wide. What happens during this wide open position? It will activate the buccinator muscle and the pterygomandibular raphe, and it will produce the desired border anatomy. For the proper lingual extension of the mandibular impression, the patient must thrust the tongue into the cheek, the opposite side of the arch being molded. Next, moving on to the distolingual extension. So what is the movement for this? The patient has to press the tongue against the lingual surface of the anterior teeth, and these movements, all the body molding movements, must be repeated a number of times once the impression has been in the mouth long enough for the wax to flow. When the impression shows evidence of complete tissue contact and the anatomy of the limiting border structures has been established, the impression is positioned in the mouth for a final time. So in the final time, it has to be left in the mouth for 12 minutes for the wax to flow and release any pressure that may be present. So this is the completed fluid wax impression. The finished impression must be handled carefully and the new cast must be poured as soon as possible because the wax is fragile and subject to distortion. The fluid wax impression technique can produce an accurate impression if the technique is properly executed. The procedure is time consuming, but if time periods are not followed, you cannot get an accurate impression. So next, we will move on to the other technique, which is called the selected pressure impression. See, the selected pressure impression, as the name suggests, you should give stress only to the portions of the ridge that are able to absorb the stress, and you should protect the other areas which cannot absorb the stress. What do you do? The entire glio surface of the tray is selectively relieved. The mandibular impression tray is selectively reduced at the ridge crest. You can see we are selectively relieving the crest area. This provides additional room for the impression material and minimizes displacement of the soft tissues. For the mandibular posterior region, the crest of the ridge is not considered a pressure bearing area because you know it is made up of cancellous bone. To minimize the pressure that will be placed on this area during the final impression, the interglio surface, that is the inner surface of the crest, is relieved down to the metal retention struts using a laboratory burr. The amount of relief is dependent on the blockout and relief procedures performed during the laboratory phases of framework construction. This is usually about 1 mm, but it may vary depending upon the partial denture design and laboratory philosophy. So, the buccal shelf is as we keep on repeatedly telling, the buccal shelf is the primary stress bearing area in the mandibular arch. So, there you give only slight relief. So, excess modeling plastic on the interglio surface should be removed and the tissue contact area of the bottom molding should be scraped lightly with a knife. Now, the lingual slope of the mandibular residual ridge, it might provide a limited amount of vertically support, but principally it resists horizontal and rotational forces. The relief provided over the lingual slope should be same as the relief provided over the buccal shelf. The impression should record these areas in a slightly displaced form. As the impression is made, the material over the crest of the ridge is not closely confined and will exert only minimal tissue-ward force because we have already relieved the crest of the ridge. This will result in minimal tissue displacement, whereas the impression material over the buccal shelf area, which is very much confined, so it will exert some more greater tissue-ward force and a slightly amount of greater tissue displacement will occur. So, the selected pressure impression technique results in a denture base which is closely adapted to and in firm contact with the tissues covering the buccal shelf area. So, the point you have to note is that on the buccal shelf area there is a close contact because it is capable of withstanding the forces. In contrast, the crestal portion of the denture base is lightly adapted to the soft tissues, resulting in minimal force application. In some patients, the soft tissues covering the ridge will be easily displaced. To obtain more relief and prevent excessive tissue displacement, holes may be drilled in the impression tray. So, this will allow the impression material to flow through the tray and dissipate pressure that might otherwise occur. As you can see, to prevent excessive displacement, we are providing multiple relief holes on the impression tray. Okay. And these are the steps in preparing the original cast and pouring a master cast. So, a master cast made from a single impression. So, now what you are going to do, you are going to record this in a functional form. So, you are going to have a new cast. So, you remove this portion. After this it will look something like this. So, the next step, that was a unilateral case. In case you have a bilateral distal extension, as they are showing, you cut out only this portion and this portion you are going to again record it using a functional form. So, you already have a framework and in the framework you have done the bottom molding and you have made the impression. So, this framework along with the impression is seated on the master cast that you have cut out. You turn it and this is the new impression, and in this area you pour another cast, that will be the altered cast. So, you can see that finally you have achieved an altered cast. So, thank you for listening to the lecture.